start. So good day, everybody. My name is Steve Wotton, and I'm here today to chair this virtual dialogue, a special focus dialogue of UICC in association with ICONIC, which is the International Collaboration on Nutrition in Relation to Cancer, which is a task force of the International Union of Nutritional Sciences. We really look forward to sharing our experiences with you today, and we hope that you will have the opportunity to contribute to the discussion and conversation, and hopefully going forward you'll also be able to join the new community that we're building that will help us all improve the care and delivery of nutritional support for children, teens and young adults with cancer. We have at the moment, we have 2 of our 3 speakers with us. We're still waiting on our third, but we'll start regardless. I'm just going to start by giving you an introduction to the need for a community. I'll then invite Professor Alan Jackson, Emeritus Professor in Southampton, who is the chair of ICONIC, and we will discuss with him some of the issues in and around providing nutritional care. And then what we will also do is we will then share the approach we are taking with you. And Rachel Marklew, who is the program manager for ICONIC and has responsibility for the Knowledge Action Portal. And what Rachel will do is take you through our thinking in relation to that portal and invite you to join us in the community. So if I proceed with, we think that childhood cancer is relatively rare in comparison to adult cancer, but we still recognize over 400,000 children, teens and young adults worldwide are diagnosed with cancer each year. We also know that the burden of morbidity and mortality associated with that cancer, both in the acute and in the longer term, and in the treatment modalities that we use to manage their cancer, have profound effects on the nutritional state and well-being. And we'll talk about some of those things as we go through the activity today. Recent work has shown there's marked variability in the nutritional approach and the resources that are available to support us in delivering nutritional care. And the challenge is not just simply to improve nutritional care in those settings which are relatively well blessed for resources, but also to consider how we can implement better care in low and middle income countries, where we have very different circumstances, very often recognizing the comorbidities that exist in those settings, the access to resources, and importantly, the impact of poor nutrition. Because we've been able to demonstrate over the years that poor nutrition has a marked impact on the child's ability to tolerate their treatment, to tolerate the cancer, both in the short and medium and longer terms. The challenge we have is how can we best identify and treat nutritional issues in children without the solid evidence and recommendations that we look for. And the only way of going forward is to share our experiences, to draw on those who have greater knowledge and understanding, and to apply that knowledge and understanding in our own settings. We know there are a range of nutritional issues to consider. We know that there are challenges of identifying children at risk by screening systems, and many of the approaches to screening, which traditionally rely on weight history, current weight, perhaps mid-arm upper muscle, mid-arm circumference, or looking at their pattern of eating, we know that we can use these tools to identify those most at risk. And then we can move to assessing the nature of the nutritional deficits and make a nutritional diagnosis. We know that we have, sorry, I'm trying to get rid of the chat. We know that we have malnutrition in its various forms. Traditionally, we would see underweight as the issue in advanced cancers, but increasingly now we recognize the presence of excess weight and obesity as a continuing challenge to screening and a challenge to thinking through how we might best manage their state. There's an increasing activity emerging in adult practice and adult oncology, which we're also now seeing coming through into pediatric oncology, where we're looking to optimize the care, the nutritional care, the activity and fitness levels, and the psychological support before we even commence treatment. This is known as prehabilitation. And the argument is that if we can better prepare people for what's about to happen to them, they'll have a better process, a better response to their treatment, they'll tolerate their treatment better, and they'll have better longer-term outcomes. Increasingly, we recognize there are a range of dietary impact factors, symptoms that occur as a consequence of the cancer or as a direct consequence of the treatment that they're receiving, that these dietary impact factors limit the ability to increase or to maintain their nutritional state and increase their intake. And it's very important that these factors are recognized early and appropriate strategies adopted to address them. This is where the role of the dietitian is so important. We also have concerns over the approach that we take to oral nutrition support. In many settings, access to commercial oral nutrition support is not forthcoming. And the challenge then is, how do we provide dietary forms of nutrition support that are based largely on the resources that we have available to us? And we'll come back to that a little bit later on. Then we can move into artificial nutrition support, whether it's enteral or parenteral, and the ways in which we can deliver this care under different settings. And finally, we have the consideration of late effects and survivorship. We now recognize that we can be very successful in treatment, but in treating our children, they're often left with a phenotype, a metabolic phenotype, which predisposes them to cardiovascular disease and cardiometabolic disease earlier in later life. When we look at the literature, there's lots of papers and publications, perspectives, reviews, and guidance that's out there in terms of how we should approach the care. But there is so much information, it's very difficult to keep on top of all of the literature. There's also literature that's being developed by various organizations, be they, in this instance, WHO and PAHO, working together to develop a guide for how we approach pediatric cancer. And there's also literature out there on the web, which is coming from charities and patient groups, where they're actually offering simple dietary advice, simple guidance on how to help your child eat well. Taking all of this together is challenging. It leads to uncertainty. Very often the evidence base is not there upon which we make these recommendations. And often the evidence might be taken from adult care without recognizing the special circumstances, the physiological and metabolic needs of the child, and the role of the parents or carers in providing nutritional support. So we have a lot of information, but we have to somehow make this accessible to people. So what we're trying to do is work together to improve the nutritional care of children, teens, and young adults with cancer. We're trying to work with the children themselves. We're trying to work with their families and their carers to identify what is it that they are seeking from the health professionals, and how can health professionals work together to provide it. We have a great body of experience and knowledge amongst our health professionals working in pediatric oncology, be they doctors, nurses, dietitians, speech and language therapists, and they're all experts in their own field, but not all of them are necessarily experts in nutrition. At the same time, we have experts in nutrition, very often nutrition scientists, who have a great understanding of the biology of nutrition, but may not necessarily have any experience of cancer, let alone in children. So what we're trying to do as part of this exercise is to work together to bring this information, these experiences, these wants and needs, this education, this learning, bring it together to try and find a way of shaping the way we deliver care that's context specific. So for different people in different contexts, we want to provide the best care, recognizing that one size will not fit all. So ICONIC was brought about as an activity which has been, that seeks to bring together the experiences of these different groups and find a way of sharing it and making it accessible so that care can be improved. It's a task force of the International Union of Nutritional Sciences, which brings together the nutrition expertise across the global states and works together to try and share and harmonize and share that knowledge that they're better placed for it to be applied in practice. There are a number of stakeholders. Initially, we have the National Institutes of Health Research, Cancer and Nutrition Collaboration in the UK, an activity that Alan and I are very much part of. We've been very generously supported by the World Cancer Research Fund International and bringing in their experiences and their capabilities. The International Agency for Research on Cancer, the World Health Organization, the International Atomic Energy Agency, and of course UICC. And working together, we have then interfaced with charities such as the Cancer Warriors Foundation from the Philippines, the Aladina Fundación from Spain, bringing together the patient-facing charities to see if we can identify ways of better delivering the information that we need. We've also got working with the International Society of Pediatric Oncology. I'm delighted to see some of our colleagues on the call, together with the International Initiative for Pediatrics and Nutrition, IPAN, out of the US. And it's by bringing these groups together, we hope and seek to find agreement, consensus. We want to share experience, we want to celebrate achievements, and we want to make all of this information available to people so that their own needs can be better met. And the way in which we have approached this is develop a community of practice. This is a phrase that's often used and it means many different things to different people. But in essence, it's just simply a group of people who share a concern or passion for something that they do and learn how to do it better together through their interactions. There's different types of communities, helping communities, best practice communities, knowledge stewarding communities, innovation. But what we're really trying to build is a collaborative learning environment that is focused on improving practice. And by collaborative learning is learning from each other. There are various ways of approaching these communities. Some is simply to form a list and send out regular briefings to people on the list. The other approach is to have various forums where groups of people get together and talk about things that they're interested in. Or there's an approach which is more of a dynamic networked approach, which isn't fixed or rigid, but is organic. It meets the needs of the people in the community, and it allows them to work with each other to better understand the things that we want to understand, the things we want to do, and finding a better way of making it happen. All the time, it's about increasing collaboration and transparency of process. There are lots of groups already out there. All are important in their own right, but we believe they can be more valuable by working together. So what we hope this community of practice will do is put you in touch with like-minded colleagues and peers. It will allow you to share your experiences and at the same time learn from the experiences of others. It will allow you to network and collaborate in order to achieve common outcomes. We're very keen that people can use this community to make new connections, meet people they've never met before, and offer them the opportunity to start their own conversations. We believe this community will accelerate your learning. It will help you better understand what to do and how to do it. But at the same time, it will validate and build on your existing knowledge and good practice. the end of the day, it's about innovation. It's about creating new ways of doing things that are better suited to the needs of the individuals. So we have a simple, if you like, dartboard with our patients and their families at the center. And we start by sharing and exchanging information. And we have a repository which will allow us to collect and collate information and make that information available to you. It's very much about accumulating experience and evidence-based learning and bringing it together to share and show how different people have approached problems so that you may find yourself how it helps you. We're looking to find consensus on the best approaches that we could use, for example, in screening and assessment, and to take the experience of different communities, for example, in the high-income countries, and share the principles back to those in lower middle-income countries, not to make it dependent on technology, but to make it much more principled base so people can find their own way of approaching that within their setting. It's about collaboration and cooperation. It's me helping you and you helping me and finding ways of doing it better together. It's about promoting synergy and harmonization. We know, for example, we now have a situation, there's such a variability in the way care is delivered. It's very difficult to actually make sense of what is the better approaches and how we might do this. And it's only by harmonizing our approach will we be able to build on our experience and learning. Above all else, it's about problem solving together. We want to use the community as a vehicle whereby people can come to the community with a problem and draw on the experience and expertise of people across the community to help that problem be addressed. We believe if we can make this work together, it will be more effective. It will identify more issues that need to be researched and better understood. It will help us identify ways of doing things, in the simple things in particular, better. We know we have a number of criteria, if you like, that will demonstrate our effectiveness in this. Sorry, use that. And that's very much about a commitment to a common purpose. Our common purpose is improving care. We want an integrated practice, multi-sectoral, multi-level, multi-dimensional in all regards. We want to standardize how we approach care, what measurements we make and how we use those measurements to infer either nutritional state or triage into care. We're very clear that one of the important things is offering training, and not just training, but also helping people demonstrate they're competent in what they do. We very much want to collect and exchange information of quality improvement approaches that you may have adopted. We want to also then build the right infrastructure, skills and resources to achieve change. The phrase that I like is that we will share seamlessly and take from each other shamelessly. There are ways in which we can do this now which are open to us, which were not open to us before COVID. New web-based collaborative learning environments are being created that allow us to connect, to communicate and conduct our activities. And what we'll do at the end of the session today is we'll share with you the work that we've been doing with the World Health Organization, who have very generously offered us their online community-driven platform as part of the WHO Global Coordination Mechanism on the prevention and control of NCDs. And one of the great things about this activity that they've developed is what's known as the knowledge action portals. And it's this ability to integrate and communicate between the various portals that really adds to its strength. And we'll share that with you as we go through. So I just wanted to give you an outline at the beginning, just simply to give you a sense of what we're trying to achieve together. We are very hopeful that we'll be able over the next period, over the next 12 months, to build on the start that we've made. It's a very early stage we're at. We're very much just moving beyond the beta version into something which is more substantive, but its success will depend upon you and how you participate with this community. There's a note in the chat. I'll just pick up on a note from Manette. Are you planning to make recommendations evidence-based, i.e. do a research project that will provide the necessary evidence to support the recommendations? I don't see it as the role particularly of the community to do that research project, but I'd like to think that the community would offer a platform whereby people who do want to do that research will work together to be able to generate that evidence and share it through the platform. Just to make the point, as Shalini did at the outset, please post your questions or comments in the chat, and hopefully we'll have plenty of time at the end to go through your points and give you the opportunity to raise questions as we go through. I'm just checking in. I don't believe our first speaker has been able to join us. I'm just looking to UICC to Shalini just to confirm that. Is that correct, Shalini?
It's correct, Steve.
Okay, that's a shame, but I was hoping that we would have today with us Carmen Aust, who is the lead of the Cancer Warriors Foundation in the Philippines. We were expecting her today, but unfortunately she's not able to join us. But her role was to talk very much about the perspective of the patient and their families and carers. And in her absence, we'll have to just park that topic for the moment, unless there are people who want to develop that idea later. But what we will do is we will focus in the future on that perspective and invite various groups to contribute to that in a future dialogue. Okay, so if I can move us forward then, our first guest here is Professor Alan Jackson. Alan is a pediatrician by training and has led the nutrition activity in Southampton and across the UK. And Alan has a great wealth of experience, both as a pediatrician and as a nutritionist. And what we thought we would do today is invite him to offer his thoughts and his experience on some of the topics that have already been raised with us as part of our discussions. But if I could start, Alan, by welcoming you here today and just simply say, first of all, you're both a pediatrician and a nutritionist. How do you draw on your respective experiences in managing children from the nutritional side?
Thank you, Steve. Good afternoon, everybody. Thank you for being on here. It's a delight to know that this is getting going. Maybe before I answer that, Steve, I could just make some comment about Carmen House, because Carmen is the reason that we're here at all. She is the mother of a child who has had cancer, and I first came across her at the World Cancer Congress 3 years ago, where she was on a panel discussing nutritional care of children with cancer, and there was a dearth of any advice or experience or any way of drawing on experience in terms of knowing what to do for the best. And Carmen approached us and said, well, what can we do to move this forward? And this is the journey that we're going on, because there is a challenge, a problem. The challenge is that we have patients who need to be looked after. We have parents who need to look after the children. We have clinicians who are looking to care for their patients, and where we're fortunate, they have an interest in the nutritional needs of their patients, but not that frequently, but they have difficulty in, particularly in resource-poor environments, of calling on that. And then we have nutritionists or dietitians who are asked to comment, and they don't always know what to say with confidence. As you said, the evidence is confusing and not clear, and there isn't a single voice that says, well, these are the underlying principles, and given your context, this is the best way of going about it. It's not that the information isn't there, but it is so varied, it is so spread, that it's difficult to know how to handle it. And so the purpose of this exercise is to bring those different experiences together in a way that we can share and know and support people so that they have greater confidence in doing what needs to be done. There's a comment about recommendations. And the question is, well, where do recommendations come from? Well, recommendations come from studies or trials, go through a rigorous process, certainly with the World Health Organization and the international agencies, and they are then crystallized into recommendations. But the process that information has to go through in order to get to recommendations is very stringent. Most people managing children with cancer only have a limited number. There are not the systems in place to allow that collective information to be brought together in a meaningful way. In my experience, I started off as a pediatrician with knowledge of managing severe malnutrition in a hospital in the United Kingdom to set up a nutrition support service. And what I discovered really very early on was this: if we took the principles that we had developed for recommendations and guidelines for severely malnourished children and applied those to patients with cancer, whether they were older patients or younger patients or children, it made a difference. It worked. The same principles applied to severe malnutrition worked in all other clinical conditions. But very, very few of my colleagues had any awareness. Most doctors training anywhere think, well, I don't really need to know a great deal about nutrition. And certainly most doctors training in the developed world think, well, what do I need to know about severe malnutrition or how to treat severe malnutrition? That's not my problem. But the reality is that the processes that take place in becoming poorly malnourished, that are a consequence of any stress or any disease, have things in common. And the processes that are required to correct those, regardless of the context, the disease, or the patient's age or condition, are the same. And so it is possible to draw some simple principles that apply in context. And the challenge that we have is to understand the context within which different people need to be managed. There are many, many contexts, but again, there are commonalities. And what this collaboration will enable is for us to draw those broad rules that will enable us to better move in the direction of developing recommendations, because that is a position that we would like to be in, but we don't have the information in an adequate form to enable that process to take place.
Alan, you said that there's a learning from the management of severe acute malnutrition that identified a series of principles that we could apply. What sort of principles might they be?
Well, the first principle is that you have to gain metabolic control. And you gain metabolic control by managing the diet. What is it that you need to manage? All sick patients are stressed. Stressed, there are a range of stresses, whether it's an infection, an emotional stress, a psychological stress, a physical stress or trauma, and it has effects upon the body, and it has effects upon the nutritional well-being of the body. But the approach to the management of the nutritional consequences of stress are common across the piece. The single most important thing in terms of gaining metabolic control is to give the patient sufficient energy, ensure they have sufficient energy to cover their needs, because if they don't have sufficient energy, they will continue to be in a negative state. But equally, not give them more energy that exceeds their needs, because if they have more energy that exceeds their needs, that in itself is a metabolic stressor. And at the same time, correct nutrient deficiencies. Now, most people say, well, there aren't that many nutrient deficiencies. The short answer is you just don't know. We do not have any useful way of characterizing nutrient deficiencies in the round. And the only way of managing that is to give sufficient nutrients with adequate energy. And the third component is to address the stressor. And clearly, addressing the stressor varies upon the condition and the situation. But those three rules, as an underlying principle, applied to every patient, enables you to start and do use for the patient and move them to a better position.
Does the stage of the patient, when we look at for example, the 10 steps in the treatment of severe acute malnutrition, the need to recognize the stage of the process seems to be very important. Is there a risk of doing the wrong things in the wrong order?
So the major challenge is to assess the severity of the insult. In the most severe individuals, the challenge is greater. And the reason the challenge is greater is that as individuals become progressively more malnourished, they lose the ability to cope. And they lose the ability to cope in all ways, and that includes dealing with the stressor. And those who are most severely malnourished have been placed in a position where their resilience, their reserves, their capacity to cope is very, very, very severely deranged. And the order in which things are done to make them better is enormously important. And so although, for example, they look as though they're very wasted, they're very poorly nourished, and the response is, well, we need to get them back to a good nutritional state as soon as possible. You do that trying to hurry things and do things at a pace actually adds to the stress and is very damaging. And so taking it at an appropriate pace as set out in the guidelines is most important. And so if you try to address the weight loss before you've corrected the derangements and the consequence of the stress, then that is a challenge. And so doing things in the right order with the sickest patients, being more cautious, is really very important. And there are accepted ways in which this can be managed. But in my experience, one of the most difficult things when you get a young doctor come to join you, or a young nutritionist or dietitian, and they see patients who look horribly malnourished, and they want to do something to help them immediately, is that they run the grave danger of being too aggressive and making the patient worse. So that at every stage, there is a need for a judgment as to what is appropriate in terms of the intensity of the support against the sickness of the patient. There are obviously a range of individual considerations that need to be taken into account, but those underlying principles operate throughout. And I'm surprised at how poorly they are acknowledged and provided as basic training for all clinicians, because they apply it across the piece.
One area that's getting a lot of attention at the moment in clinical nutrition care is protein. And there seems to be a preoccupation with giving more protein, and seeing a patient who has lost body protein through undernutrition is often seen as a trigger for giving more protein to try and make them replete. What are your views on our approach to protein supplementation or high protein feeds?
Well, I'm of an age where when I first graduated, we were in the stage where people who had presumed that all malnutrition was due to protein deficiency realized that that was not correct. And that if you fed patients on higher protein diets before they could cope with them, that was a major cause of mortality. And so we're going through a loop that 60 years ago we had already addressed. There is very little evidence. Patients have to have enough protein, but there is very little evidence that giving them more protein confers benefit. Indeed, if the evidence shows that the two things that are protective against cancer is having a very modest energy intake and having a limited protein intake. And certainly in preclinical studies, if you want animals to develop cancer, then you make them overweight or obese, or you give them high protein diets. And one can work through the good reasons why that is so, but it is unhelpful in patients at the start of their care to give them more protein than they require. Although there are situations when, as you give them more food, then clearly you give them more protein, but it is more protein in proportion to the more food. And so the more food based upon increasing the amount of energy is obviously important for regaining weight, but the protein needs to be proportionate to that. And there is very little evidence that the converse applies. In fact, I would almost go so far as to say there is no good evidence that that is so, and there is a worrying amount of evidence to suggest that it is potentially harmful. And it may be that this is a particular point that this community needs to explore in greater detail and to share experience on, because it is such a contentious point that drawing everybody's experience in and laying that out and looking to see how it compares would be a very valuable task to carry forwards. So I think that what you have the point you've just made, Steve, is a very good example as to why we need this community, because I've given my opinion. I'm not going to tell you that my opinion is correct. There may be others with different opinions. And I think one of the more important things that we can do is to explore the reasons why we have different opinions, how those different opinions play out, and what would be the most appropriate way to address them. It may be that the different opinions are on the basis of our different experiences in different contexts and are legitimate for those different contexts, and we need to be clear on that. It may be that our different opinions are just are not based on any secure foundation, and we need to be clear about that. And more importantly, we need to be clear about how we can move to a more secure foundation, because the last thing that we want to do is to be doing things to patients on insecure evidence that actually doesn't help patients or potentially makes things worse. And we don't know this information. The communities around the world have all sorts of reasons for doing different things. And that is a good example of how we would hope that having this community will enable us to bring the evidence together and share it. I, for many years, worked with the World Cancer Research Fund, looking at the evidence for dietary exposures and risk of cancer. All of the evidence was in adults, very little in children. one of the reasons why is that there isn't very much evidence in children on a global scale. In fact, there isn't much evidence on a global scale for anything. And on a global scale, the World Cancer Research Fund offers advice based upon the evidence, but virtually none of it is from the lower income countries. And we have no idea whether the same rules that have been adopted apply across the globe in the same way as they apply in Western Europe and North America. And so again, that is a second obvious and important opportunity whereby sharing information, we can actually develop a framework where we can capture the information that is available, where people can, within their own practice, take greater cognizance of the considerations and feed into an information structure that would allow us to come to better positions than we have at the moment.
Thank you, Alan. That's a very well made point. I think the evidence for the value of these community-based approaches, to me, was exemplified in two settings. One was in Crohn's disease with the Improve Care Now program, which, without actually bringing together any new evidence, was able to increase the number of children in clinical remission simply by building on the collective experience, identifying the simple things where they agreed to agree, and focusing on delivering those over and above spending time trying to work out all the reasons why they disagreed. And that was a very successful program. The other successful community program was the Vermont-Oxford network for developing better care for neonates and preterm infants. And again, by sharing their experiences, sharing their evidence, their information, they were able to come to better ways of doing things. And through a series of quality improvement cycles, were able to actually impact upon the way care was delivered. And then with that impact on care, they were able to look to see what difference it made to outcomes. Sometimes it made a difference, sometimes it didn't make a difference. And exploring why that was very, very important for them. But I think the messages you've offered us there are very straightforward messages around thinking of the stages of care, doing the right things at the right time, thinking through how we bring experience together and how we capture evidence are clearly going to be important parts of our activities going forwards. I'm going to park it there, Alan, if we may, because I'd like to invite people later on to come back with their thoughts or comments. Actually, no, let's take that now, I think. So what I'd like to do, Shalini, before going to to Rachel and the Knowledge Action Portal, perhaps we could take this moment to invite questions from those who've joined us today. Does anybody have any specific questions or points they'd like to raise as part of this discussion? If you do, put it into the chat. If you want to speak, if you could just please indicate that you'd like to speak, and then we can make that opportunity available to you. I'm delighted we have colleagues from SIOP and IPAN here today. One of the things we want to do is to use this opportunity to promote their work and the activities that they're engaged in. I'd be very happy if anybody from SIOP or IPAN wanted to say anything or raise a point. All very quiet out there. Okay, if there are no questions, what I'll do is I'll move through to inviting Rachel Marklew to share with us what we've been doing on taking advantage of the support of WHO and the Knowledge Action Portals to show you the sorts of things that we're developing, and at the end of which invite you to join us on this system so that you can actually share your ideas and your thinking with us. Rachel, I'll pass over to you.
Thank you, Steve. I'll just share my screen. Can you see the screen?
Yeah, we have it. That's up.
Thank you. Okay, so as Steve has said, we've been working through with the Cancer Warriors Foundation and others to explore how we might achieve establishing a community of practice. And we were introduced to Dr. Sam Sieber at the World Health Organization, and who has worked with us to create a platform and to host the community. So I just wanted to talk through that platform. And first I'll talk about just a general overview of the Knowledge Action Portal, and then I'll specifically talk about the Nutrition and Cancer community that we have created. So the WHO, the Knowledge Action Portal, it's a knowledge sharing and community driven platform that's addressing the impact of NCDs, and it presents users with an innovative way to enhance global understanding, interaction, engagement across sectors, and to help fulfill existing commitments to NCD prevention and control, but also to initiate new commitments, and as Steve said, to encourage collaboration and engagement across the world. So it's hosted by the World Health Organization Global Coordination Mechanism on the Prevention and Control of NCDs, and it's dedicated to multi-sector collaboration. And as Sam Sieber pointed out in the session he spoke for the World Cancer Congress session, and also Steve earlier said, it's realizing that no actor alone can tackle NCDs, but rather requires people working together. So I'll just show you here, there's two important pillars the CAP was created for. And firstly, it was bringing together the evidence in one accessible global platform, a repository. And it operates with the understanding that while there is the gold standard evidence, so systematic reviews, RCTs, which is important, as Steve said, there's increasingly acknowledgement of other forms of evidence and insight, and that includes insights of those living with NCDs as well. And the second pillar is the translating the evidence into tangible policy change and action. So I just start by saying that the Knowledge Action Portal is free to join. So there are areas you can have a look at on the portal that you don't need to become a member, but to join the communities, which I'll show you in a while, you do need to register as a CAP user, but that's quite straightforward, and it's I'll show you how to do that in a moment. So as you can see here from the tabs, there's three main sections to the portal. So there's the public knowledge repository, which is really a collection of evidence, publications, guidance, reports. And the idea is to have in one place a better picture with resources all in one accessible global repository, which is accessible to everyone. And then the second part of the portal is an action, focused on action. And here you can find, for example, a collection of country stories, case studies, so maybe success stories, and then news and events relevant to this area. And then the third section is the community section, which is the CAP's more interactive feature where people are invited to contribute. And I'll show you, and this is where the community, you can see here, nutrition and cancer, children, teenagers and young adults. That's the community that is a new community that we established and want to talk about today. So before I go into the communities, I just wanted to point out over here, you can see there are also user collections. So if I just take you here, so anyone can create a user collection, and it might be for a meeting coming up or a cross-cutting initiative. And really it's a match of resources, both external, so in terms of external links, but also to resources that are already hosted elsewhere on the CAP. So we do have a new, to show you here, you can search collections. We have a collection on nutrition and cancer here, so it's new and we're looking to build that, so we're very open to ideas of what people, the community would see would be valuable in this section. And then if I move on to the community itself, so I've logged out here so that I can show you, but if you can either access the communities by clicking directly here, or if I just click on the tab, you can see that this is a list of all the communities of practices that they're being hosted on the CAP. So there are a range of communities, some are private and some are open. And you can see there are a range in terms of how many members there are and resources, and each community will have different features. Okay, so if I go down to us. So this is the Nutrition and Cancer in Children, Teenage and Young Adults community, and all you have to do is click on, and it will ask you if you want to join the community. So to do that, if you haven't already registered as a CAP user, you just have to create the new account here, which is relatively straightforward. And if you have any problems, please do let me know. But I'll just log in. So the Nutrition and Cancer and CTYA community is a new community, and we've very much used existing templates that the other communities used to get started. But we will be looking to work with World Health Organization to create new features for the community. And again, we're very open to ideas about what people would like to see here or what people think would be useful. Just to say at the beginning, it's very much focused on, so currently the content really is for health professionals, clinicians, researchers to seek consensus on best practice. But over time, we would want to create a space perhaps for those young people with cancer and their families to exchange experience, raise concerns to be addressed. So as I said, communities can be either open or closed, or there is the option to have both as well. So it might be that we have closed areas perhaps, and then more open areas for patients. And as Steve said, that's something that we will be looking to do later on. So I just go through the pages. So this is just the home page, and it just gives a brief overview, some key messages. There's a preview of the notice board, and then also a community calendar. And I'll show you the calendar in a moment. And then the about section, just again, an overview of what the community is about, and some of the people we've been collaborating with. And then also, again, just key messages, and that's something we can build over time. In the event section, so here we would just be trying to, the idea is to post up and coming events that are relevant for the community, might be of interest. And you can just see here, today's event is just showing there for November. And then there's also the option to, once an event's happened, you can then, so for example, today we will post a recording of the event. So for anyone who wasn't able to join, they would be able to access a link. So it would provide an external link to UICC's website so that they could access that. And then the main thing I wanted to show you today, and I suppose it's the main, the most active part of the community at the moment, is the notice board. So at the moment, this is moderated by myself and with the help of an editorial team. But eventually it will be something we could open up so members of the community could post themselves. And you'll see there's you can have a look in your own time, but you can see there's a number of different types of posts. So we have one there which is showing today's event, so with a registration link. We have some resources on there, so one of the editorial board, Stevie Schumann, has kindly provided links to CIOPS educational sessions, which are generally for closed members, but then recordings are available. So that's just another example of something that could be added here. So different events, recordings, perhaps new papers that have been published that might be of interest to the community. So you can just see on the notice board, there can be a range of different posts. And then the other one that we would really like to encourage is questions. So we plan to post regular questions here, and if you click on a post in the notice board, there's an option to comment. So as you can see, this is where we'd like, so there's a questions posted, and then we'd like to encourage the community to discuss and share their experience, and just respond to the questions that are there. But again, we would be very open to ideas of questions that would be good to post here. And as I say, over time, people will be able to post their own questions to initiate discussion. So I'll just go back. So each of the notice board posts has the feature to comment, but over time we may create a new tab up here, which will be a discussion tab where we'd be able to initiate different discussions there and encourage dialogue in the community. Over time, again, at the moment we are in the background creating a collection of curated resources to hopefully, so as I said, there is a public knowledge repository, but we would be looking to have a community repository, which would be a more thematically focused element for sharing resources with the community. So we're gathering resources that may go there, and perhaps in Q1 we'll be looking to have that live on the website. So again, it's something that we would be very open to ideas from the community about what they would like to see there or what should be there. And that, I'll just show an example. So this is one of the other communities, the Grassroots Innovations on NCDs, and I'll just show you, they have a repository. So you can see here, there's just different publications and resources posted. You can search, and they have different topic areas as well. So again, we would be looking to have topic areas relevant to nutrition and cancer in children. And that's something that we'll be hoping to roll out in Q1 next year. The other element of the community for the future that we're thinking about at the moment is a stakeholder mapping model. So this is an example again from the grassroots community. So you can see here, so when you sign up to this community, you're asked a few questions. So that's an option we could include for our community as well. But you're asked questions, and then the information is gathered and then shown here. So you can just see the kind of questions that people were asked, and then it just means that it's a database of the members, and people can connect with others basically on the community. Okay, so I'll just go back to this one. So to join, as I said, all you need to do is sign up for a CAP user account, and then you're able to join any of these communities that are shown here. And if you have any problems with that, do let me know. And I just wanted to say, I think as Sam at WHO has said in his presentation, he said before that the community will really be as good as the contribution and the material submitted and the engagement there. So it's a real community effort, and so ICONIC is facilitating that, but we're looking to the community to contribute and engage with each other. So that might be through providing papers, materials, letting the community know what events are coming up, and then initiating discussion. Yeah, so if you have any questions or resources or that you'd like to see, or any other ideas for the community, then we would very much like to hear that. I think that's probably all, Steve. So yeah, please do have a look. And if you have any questions, let me know. Thank you.
Okay. Thank you very much, Rachel. You want to close it off your screen? And we'll be very happy to share this information with you as a post dialogue note on how you can join the community and be part of it. I think the important thing, as Rachel has stressed, is it's your community. It's up to you. We can provide the platform, but it's very much around you raising the issues that matter to you, and us working collectively together to try and find those answers. If you are going to join now, please do so. The team at WHO are very happy to accelerate your joining, and you'll be put through straight away into the system. It's very much a beta site. We're still in development. We expect to be fully loaded, as they say, for the Q1 of next year. And we'd be very, very keen to know from you what it is that you would find most useful on such a system. I'm looking at there's nothing in the chat specifically, I don't think. Or that's the link you've provided there. Is that Rachel?
Yeah, that's a direct link to the community. So if you follow that link, you can create an account that way, and then access the community directly.
Okay, I was just about to say, are there any final calls on any questions? And Manette's back here again with a question. Thank you, Manette, that's really helpful. Would it be possible to come up with 3 questions around nutritional state that everyone can implement in their research, and then pull the results to start building some evidence around treatment and nutritional state? Kind of like a nutritional state registry or a component of a registry. I think this is a great idea. I recognize the challenges of getting nutrition questions or nutrition issues, measures of nutritional state into the existing cancer registries. But I'd be very keen to see a way in which we could work together to start collecting information. This is exactly where improved care now in the management of children with Crohn's disease was about 10 years ago in America. And it's quite clear that they have something of great value by pooling, for want of a word, people-based evidence, data collected at source, in a way of actually gathering in the information which would otherwise be difficult to do. Jeremy, you'd like to Jeremy Sloan is on the line, on the call. Jeremy, I think we can unmute. Is that right, Shalini?
Sorry, I can unmute. I couldn't figure out how to raise my hand. I don't know. My icons are a little tricky today. But just, yeah, something I wanted to add. So I am the immediate past co-chair of the SAP Nutrition Network. So I just ended my term a few weeks ago. There were a couple of members of the steering group here, but I think they've had to leave. But I'll just add one thing that that sort of builds on what Alan was talking about and goes to this question a little bit here as well. And a couple of years ago, in the SIOP Nutrition Network steering group, we sort of asked a very similar question to this one of what are the unanswered questions, like where is the evidence lacking in nutrition related to children and young adults with cancer, and one thing that we thought of was especially many of us were clinicians. I'm a pediatric oncologist, and so we thought of we're often not sure how to address chemotherapy dosing when it comes to someone who's very, underweight or very overweight, and are we increasing toxicities by giving a full dose? And I used to live and work for many years in Southern Africa, and so we used to make clinical decisions in absence of evidence of trying to avoid toxicity. But so we set out to at least try to understand this question a little bit better. And so we have just finished and submitted for review a systematic review on the pharmacokinetics of chemotherapy and body composition in children and adolescents with cancer. And so hopefully it's positively reviewed in print in the next few months or next couple of months. But I think what I can say is that from that experience, going back to something that Alan was saying about evidence, is that evidence is out there. It's very confusing. And one of the things that we found is that the definitions, the terminology, the metrics measured, all varied widely to the point to make comparison essentially impossible. And the whole medical science and peer-reviewed literature is supposed to put us into a place where if my institution does a study and someone reads that paper, it could be repeated somewhere else and hopefully find the same results and validate the results, or maybe challenge those results. And unfortunately, with childhood cancer and adolescents and young adults and chemotherapy, that evidence is essentially almost impossible to compare. And so the way we saw this, and we weren't shocked. This was not a surprise to us. But we felt that at least needed to be out there, that this is what the current evidence is. And as I was telling the team as we were putting this project together, that the significance of the project would probably be in 10 to 15 years when it's repeated, and someone references, we'll probably not be involved in that project, but someone will reference our systematic review that show, that said there was widely variable terminology and metrics measured, and that, somehow maybe people started to use more common terminology and common measurements and common pharmacokinetic measures. But so that's what, one of the things that the PsyOp Nutrition Network has been involved in. Even though I'm not in leadership there anymore, I'm still involved with the network. And Wim is on here. He's been very, very, very involved with that for many years, and others. So PsyOp, I'm sure, looks forward to continuing to participate in this forum.
Thank you very much, Jeremy. And I think you raised two important points there. One is, when this new knowledge is in print, one of the things we can do through the community is signpost folks so that they can actually access the content, find out how to do it. And one of the challenges is then the second key point is, where we have an absence of evidence, both in the published literature, but we have a clinical need, then we need to be a stronger voice collectively, advocating for the right sort of research, using the evidence that is available to highlight what we need to do next. And I'd like to think that if we can start connecting better across the communities, colleagues in high-income country settings offering support to those in lower middle, and people in lower middle income countries who have experiences that are of value and should be shared, can inform those in high-income countries. And that networking capability, I think those of us in high-income countries can strengthen the applications of those in other settings by either just simply offering support and mentorship or offering direct involvement. I think will make a huge difference for everybody. I think at the end of the day, we need the evidence as best as it exists. We need to know what is secure and what is not secure. And in a lot of cases, certainly in the adult oncology setting, there's an awful lot of information out there that actually interferes with understanding. And if we can talk to each other and communicate with each other, we can perhaps avoid some of those complications that have arisen. People making comments on gold standards of methodologies and the likes always gets very complex. But thank you very much, Jeremy, for joining us today. And Wim, we're very, very keen to support the work of PsyOp and to extend the work of PsyOp into other communities who perhaps aren't a member and therefore know the valuable work that you guys are doing, and hopefully can expand the experience. So thank you, Jeremy. Point well taken, and we wish you well with your publication. Wim, is that a hand from Wim?
Yeah, maybe I can add. Thank you, Jeremy. And I think the good thing of this network inside, we're going to try to look at evidence and come up with some clinical practice guidelines. But I think the good thing of this network is that in SciAP we've only pediatric oncologists, pediatric dietitians, but in this network there's a whole bunch of nutritionists, etc., researchers with other inputs from which we can learn as well. So I think combining efforts would be wonderful to, in the end, come up with at least some guidance for the practitioner.
Thank you, Vin.
Only addition.
I think in the absence of evidence, you still have to care for the patient.
Exactly.
So I think pulling the evidence that we do have together, learning from adult care, where we can learn from adult care, and applying nutrition principles in practice, I think will help us all move forward.
Yeah, and I think that's what Alan said as well earlier.
Yep.
Yep.
If there are any other points or comments anybody would like to make, if you'd like to raise your hand or unmute and voice speak. Okay. I'm looking, I can't see any other comments there, but just to thank you for joining us today. We really do want to expand this activity as far as is possible. Rachel has provided a link to there in the meeting chat. With Shalini, we will be sharing further ways of communicating with this activity. And we would very much welcome the opportunity to continue these conversations. I think it's only through the conversation will we find a better way of doing things. Can I thank Alan and Rachel and Shalini at UICC for your help in pulling this together today. I wish you a very good day, and I hope that the rest of your day goes well. Alan, is that something you want to finish with?
No, I just wanted to say thank you, goodbye, and all the very best.